Hey everyone, this is Rona again, Internal Medicine PGY2 at Walter Reed here with another shelf review video. And today I wanted to start off with a couple of electrolyte conditions. So let's say you have a 21-year-old female with a history of celiac disease who's now presenting with muscle spasms and QTc prolongation on her EKG. You notice that she has some facial nerve twitching and spasm of her hands after blood pressure cuff inflation. So this is actually going to be the one for hypocalcemia, and the celiac disease may be pointing to vitamin D deficiency as a result of malabsorption. Just remember that you can have a similar presentation of vitamin D deficiency and hypocalcemia with someone after bariatric surgery. The QTc prolongation is going to be an important sign of hypocalcemia, and this question stem is giving you two other high-yield signs to remember with the other physical exam findings. So these are going to be your Trossard's sign and the Trousseau sign. So the first is going to be when you're tapping the facial nerve, that's going to cause facial nerve twitching. And the second one is going to be when you inflate that blood pressure cuff and you know that you have the hand spasms after cuff inflation. So I always forgot which direction the PTH caused the calcium to go. So just as a review, is PTH going to cause the calcium to go higher or lower? So PTH is going to cause the calcium to go higher, and I actually learned this when I was a medical student, where remember that PTH is standing for phosphate trashing hormone, and obviously that's not the correct abbreviation, but essentially it helps you remember that if you have phosphate going lower, then calcium is also going to go in the opposite direction. So if PTH is low, calcium will also be low, and you can imagine that if someone had something like neck surgery that caused injury to their parathyroid gland, that could cause calcium levels to go lower. And what other electrolyte abnormalities should you be thinking about if you're trying to work up someone for hypocalcemia? And this is going to be magnesium levels, because low magnesium levels can also negatively affect PTH functioning and cause hypocalcemia. And which thyroid cancer can cause hypocalcemia? So this is going to be your medullary thyroid cancer, which can cause hypocalcemia by increasing calcitonin secretion. Remember, calcitonin will help tone down the calcium levels. And what would you expect with osteoblastic and osteolytic lesions? Which of those two conditions would you expect to be associated with hypocalcemia? And this is going to be your osteoblastic lesions. Remember, osteolytic lesions are seen with multiple myeloma. Osteoblastic lesions are commonly seen with things like breast and prostate cancer, and these are the ones that are associated with lower calcium levels. And what if you have someone with a history of alcohol use with epigastric pain that radiates to the back, and you also note hypocalcemia? What is this person coming in with? So that alcohol use is going to be a risk factor for pancreatitis. You're seeing that characteristic epigastric pain that radiates to the back. And just remember that hypocalcemia can be associated with acute pancreatitis. And now what if you have, thinking back on a previous video, someone who has that triad of medullary thyroid cancer plus a parathyroid adenoma plus a pheochromocytoma? Which genetic condition are you thinking about in this case? So this is going to be your MEN2A. So just thinking back on this figure here, remember that medullary thyroid carcinoma is going to be present in both MEN2A and 2B. And then the parathyroid adenoma, which can lead to primary hyperparathyroidism, is going to be your MEN1 and MEN2A. And then remember again, pheochromocytoma is the one that can be both MEN2A and MEN2B. And now let's shift gears a little bit and say you have this other scenario where you have a 21-year-old with a history of cancer. Maybe they just recently had some chemotherapy for maybe some blood cancer. They're coming in with elevated potassium levels, high uric acid, and low calcium levels. Why do you think they're having this constellation of lab abnormalities? So this is going to be your tumor lysis syndrome, and this is a concept that is very confusing, but this figure is kind of helping to show what's going on. So you have high cell turnover, and that's going to cause things like potassium and phosphorus to release from the cell. The cell is also going to be releasing nucleic acids, which ultimately break down into uric acid, and because of this high phosphate level, you're also going to have binding of calcium, which leads to lower calcium levels. And which other electrolyte other than the potassium and the calcium should you check for this patient? And we just went over this in that previous slide, but this one is going to be phosphorus. And I always forgot which of the electrolytes were elevated and decreased for tumor lysis syndrome, especially when I was stressed during the exam. But someone actually taught me this mnemonic. So just remember that puke calcium mnemonic, where the E is going to stand for elevated. So this is going to help lump everything that's elevated together. So phosphorus, uric acid, and potassium are all going to be elevated. Calcium is the only one that's going to be decreased. So that can be something to keep in mind when you're selecting things on your exam. And now, what could you do to help prevent tumor lysis syndrome in someone where you believe that they're going to be high risk? And the answer for this one is going to be make sure that they're receiving fluids before chemotherapy and hydrated. Xanthine oxidase inhibitors like allopurinol and febuxostat, which help to prevent the formation of uric acid. And you could also consider rasburicase instead of a xanthine oxidase inhibitor if you're seeing that on your exam. And there is one population where you should think about testing for something before giving rasburicase. Can you think about when it might be contraindicated? And the answer for this one is going to be your G6PD deficiency patients. And now switching over from hypocalcemia to hypercalcemia, which symptoms would you expect with hypercalcemia? So this is going to be your stones, bones, groans, moans. Some of you may have learned it as psychiatric undertones, but it's going to be a constellation of kidney stones. You'll have bone remodeling and increased fracture risk. Those GI symptoms like nausea, vomiting, constipation, and then some of those psychiatric manifestations like lethargy, memory loss, and depression. And say you have a patient with advanced hyperparathyroidism, you notice they have multifocal areas of this subperiosteal thinning and cystic degeneration on their x-ray. And there's a certain buzzword the test might be having you think about with this constellation. Can you think about what that one is? So this is going to be your osteitis fibrosis cystica. And this is a picture of someone who's coming in with chronic severe hyperparathyroidism. And ultimately what's happening is you have these overactive osteoclasts. And here, figure A is showing a humeral fracture and B is showing a femoral fracture, so fractures of big bones. And then these astraces are showing these lytic lesions that correlate with areas of excess osteoclast activity. So you see here, this asterisk here, you have another one that's up here. And those are all, you might also see it as brown tumors on your exam. And for hypercalcemia, when would you categorize someone as severe? So this one is going to be if their calcium is above 14 or they're symptomatic. And how would you treat someone with severe hypercalcemia? So the most important thing on your exam is going to be fluids. So thinking about giving them some normal saline. You can also think about adding things like calcitonin and then long-term addressing the underlying cause. And then you can consider adding IV bisphosphonates as well. But fluids are going to be really the most important thing. And which lab do you want to get next as part of your hypercalcemia workup? So that's going to be your PTH, and that's going to help categorize whether someone is PTH dependent or independent. So what if you have someone who has hypercalcemia and the PTH is high or it's high normal? What would you think about as the cause for this patient? So it's going to be your hyperparathyroidism. And what if the calcium is incidentally mildly elevated? Maybe it's someone who's coming in for their annual exam. They say they're not having any symptoms. Their kidney functioning is normally. And then they say that their family has a history of hypercalcemia as well. What would you think about for this one? So this is going to be your familial hypocalciuric hypercalcemia. You might see it as FHH. So FHH is going to have that autosomal dominant inheritance. They're going to be asymptomatic. A lot of the times it's people who come in and they have incidentally found hypercalcemia on their labs, normal renal function, and it's going to be the mutation of that calcium sensing receptor. So you might see that on your exams. And I had this on my year-old exam that the urine calcium creatinine clearance ratio was low. So it's going to be that less than 0.01, which is different from what you would expect for primary hyperparathyroidism. But I think these are the highest yield things for FHH. Going on to a different scenario for hypercalcemia, what if you have a 24-year-old female, you notice that she has elevated 125 dihydroxyvitamin D, elevated calcium levels, and she's also coming in short of breath with a skin rash. So this is going to be your sarcoidosis. And which cardiac complications would you want to screen for? There are a lot of different organ manifestations for sarcoidosis, but a couple that are that are a little more high yield for your exams. So there's going to be heart block, especially if you see someone with heart block who's young, keep sarcoidosis in the back of your mind. And if you took a biopsy of an affected organ for someone with sarcoidosis, what would you expect to see on histology is maybe a buzzword on your exam. So this is going to be your non-case-eating granulomas. And what if this patient is coming in saying that she has these painful subcutaneous nodules on the interior lower legs? And this is not going to be specific to sarcoidosis. It can be seen in other things as well, but this might be pointing to something like erythema nodosum. And why are you seeing an increased calcitriol for patients with sarcoidosis? And the reason for this is that you have these macrophages that are activating and increasing conversion, so it's not done by the kidneys. And because of the increased calcitriol, you're going to have increased calcium absorption, which is causing that hypercalcemia. And what if you see someone who's coming in with sarcoidosis and you know that she has these violaceous facial lesions, maybe a lesion on the tip of her nose, maybe some on the cheeks of her face? So this is going to be your lupus pernio. And what eye condition can be associated with sarcoidosis? And the answer for this one is going to be anterior uveitis. And then there are a few other high yield things for sarcoidosis as well. There's another type of facial movement involvement you could see, something like facial nerve involvement. So if they're unable to move a side of their face, that can be a sign. You might also see things on their face like bilateral parotid gland enlargement. That can be something you see on your exam. And then what might you see on chest x-ray for someone with sarcoidosis and lung involvement? So the big keyword here is going to be that bilateral hilar lymphadenopathy. Sometimes you can also see interstitial infiltrates, but you don't necessarily need to. That bilateral lymphadenopathy is really going to be your main takeaway. And what would you expect the PTH to be for someone with sarcoidosis? So you would expect it to be lower, and the reason is that the hypercalcemia is because of this increased calcitriol from your activated macrophages. So that's what's increasing your calcium absorption, and your body is going to try to compensate through negative feedback. So they're going to try to decrease the calcium by decreasing the PTH. And what is the treatment for sarcoidosis? And the answer for this one is going to be your steroids.